So I'm going to turn it over to Dr. Henson.
All right.
And he's going to talk about supervising autonomy.
So if you look in your program about what the next 40 minutes would be about, the title of it that you would see is Balancing Supervision and Autonomy. The very nature of that title implies that these two things, supervision and autonomy, exist at opposite ends of a spectrum, or on two different seats of a seesaw. So I want you to leave here, as you think about your role as an attending physician, not thinking about balancing supervision and autonomy. I want you to leave here thinking about, and you see that I've slightly changed the title of my little talk. I want you to think about what it looks like for you in your little niche of academic medicine to supervise autonomy. To supervise autonomy. Not for supervision or autonomy to exist on opposite ends of the spectrum, but how do I incorporate these two things together? And how do I supervise autonomy? Now, I'm going to assume something over the course of the next 40 minutes of our talk, which is maybe not fair, but I think important just for the sake of the time that we have. I'm going to assume that you, in your hospital setting or your clinic setting, are feeling external pressures, perhaps internal pressures too, but definitely external pressures towards supervision. That you are being encouraged by whoever the they that we want to make they be, you are being encouraged by them to supervise more closely, to watch more carefully, to pay better attention to what's going on, to not let people make decisions they're not yet capable of making. I'm going to assume that that's the angle that you're dealing with. I might be wrong, but I think for most of us who are dealing with things like length of stay, or dealing with things like high-value care, an emphasis of the ACP among other organizations, that we feel a burden as faculty members towards over-supervision. Back up. We feel a burden towards supervision, not necessarily over-supervision. But we feel that burden and that push. And so as we talk over the next 40 minutes or so, I want you to think about how can I still answer that call to high-value care, decreased length of stays, less readmissions, and yet still provide trainees autonomy. Because I think as far as where the rubber meets the road in education, that's the question we have to answer. All right, I don't have any disclosures either. Our objectives over the next 40 minutes, similar to what Dr. Thigpen mentioned, I want to talk a little bit about the balance of supervision and autonomy, and I want us to think just about that big picture stuff. We can't get into all the nitty-gritty details of it. But what I actually hope to do more than anything else is to leave you with a toolkit to implement in your own practice and in your own career ways that you can provide trainees autonomy yet still supervise them appropriately so that patients receive optimal care. Now, you don't have to search real hard to find medical education literature on supervision. That's been the low-hanging fruit of the last, well, particularly since 2010, 2011, when the ACGME introduced common program requirements that more overtly talked about levels of supervision. This has become something that people write about, something that people do studies on in their own institution. This one was published in July of 2018 and actually received some notoriety in the lay press. So not just in our own medical literature, but in layman's literature, or not literature, but layman's news feeds and things like that. This was a study done at Massachusetts General Hospital, and without getting into all the details of it, it was really a neat study. They took 22 of their best inpatient general medicine physicians, and they did a crossover study with these 22 attending physicians, comparing what are the medical errors, that was their primary outcome, what is the rate of medical errors with what they called highly supervised residents versus those with less supervision. So what does the rate of medical errors look like? And just to give you an idea how their institution may differ from yours, what they considered highly supervised residents were residents for whom the attending saw both new patients, new admits, and old patients together with the team in a day's work of rounds. And then the control group, or the less supervised group, were those where the attending physician saw only the new admits with the team, and then essentially card flipped, as most of us like to say, card flipped or just went over the plan on the old patients that had already been in the hospital for several days. So that was their two groups. They crossed over, so the attendings did both arms of the study. But this is what they found as they compared those two things. They found no change, no difference in the rate of medical errors. They actually found no difference in the length of rounding time. And so the way this was reported out to the lay media was something to the general effect of, attending supervision makes no difference in medical errors. Now, does anybody here really believe that? I don't know. We have some residents in here that might believe that. I don't know. I've been times where I felt like my own over-supervision probably didn't change the rate of medical errors, because I had a really good resident who actually probably was a little bit better taking care of the patients in the hospital than I was, quite frankly. And so there are times that I have felt that way. Well, that's how it got portrayed to the media. But there were a couple other things that I want us to give a little bit of nugget to, and this was survey data with the residents who participated in the study. Number one, they actually saw that when the attending was around more, the interns spoke less. That's actually not survey data. They had somebody following the teams around and clocking how much time was spent speaking by each individual. But the interns spoke less when they were a more supervised team. From the survey data, they found that interns considered themselves less efficient when they were supervised more closely, less efficient, and residents considered themselves less autonomous in making decisions when the attending physician was around more. This is a quote that comes directly out of their paper. Obviously, it's a lot of words to read on a PowerPoint, but you can look at the underlined stuff to hit the high points. So, without the attending physician on work rounds, residents believed that they were the team leader, and their comfort in making independent patient care decisions improved. So that was their belief. Okay? I'm not saying it was right. I'm just saying that's what they reported as their belief from this paper. And then residents in both the control and intervention arm, and I found this interesting, residents in the control and the intervention arm believed that they provided the same quality of care. So the residents didn't feel like the quality of care improved as the level of direct supervision improved. And then finally, the attendings had a slightly different impression. Attending physicians believed that they knew the team's plan of care better, rated the quality of care higher, and felt more satisfied with the care provided when they participated on work rounds. In other words, when they supervised things a little bit more closely than in the control group. So, let's think about what that does then for our team dynamics just a little bit. So Dr. Thigpen mentioned this book published by Gallup that looked at the things that make for an effective work environment, 12 things that effective managers can do to make their own organization receive better scores, I guess, from its employees, if we want to put it that way. And number one of that on that list, of course, as Calvin mentioned, was I know what is expected of me at work. Somewhere else on that list, and I actually don't remember the exact number this one was, but this is another one that rated fairly highly among employees of organizations. That is, I have the opportunities at work to learn and grow. I have the opportunities at work to learn and grow. So employees that felt more engaged in the organization they were working for were those that felt like they had the opportunity to develop their own skill set, and as that skill set developed, gain more freedom, gain more autonomy, if we will. So this perception of theirs was important for their own assessment of the organization they worked for. I don't know that that's not terribly untrue about residents and fellows and interns that we work with as well. I don't know that that's not terribly untrue about them. So as we think about supervision and autonomy, let's get a few things out of the way first just to get us all on the same page. Supervision is incredibly important. As attending physicians, as senior residents supervising students and interns, it's imperative to us that we supervise to a level to ensure that the patients that we are currently taking care of receive quality care. Supervision ensures the quality of our present patient care. Patients in the hospital or in the clinic right now. Supervision ensures that they receive high quality care. And yet, perhaps equally important, autonomy ensures the quality of future patient care. Autonomy ensures the quality of future patient care. We still train, by and large, through the clerkship and the residencies in apprenticeship type learning, where it's incumbent upon us to help our learners develop their own style, develop their own thinking. Somebody in the audience mentioned, as Dr. Thigpen asked the question the last time, that example that he gave last hour, they didn't really know how to think. So it's incumbent upon us to both teach them and allow them to practice their own thought process, their own development of that. So what is supervision? Well, this is an old definition of supervision, and I don't want to spend too much time on it. But clinical supervision is the provision of monitoring, guidance, and feedback, so there's 3 levels of it, on matters of personal, professional, and educational development in the context of the trainee's care of the patient. So it's we watch, that's the monitoring, we guide, we advise, and then we provide feedback. 3 steps to supervision. An important part of supervision is that the definition includes the ability to anticipate a trainee's strengths and weaknesses in particular situations in order to maximize patient safety. One of the things we'll say frequently over the next few minutes is that supervision never exists in a one-size-fits-all model. We as attendings, if you're an attending in here, you can't supervise every trainee that you're ever going to work with at the exact same level, or I guess you can. But if you do, you're probably going to be over-supervising many and under-supervising many others. So we have to be the ones who conform our supervision. We have to be the ones who are changing based on what the learner needs. You'll remember that the ACGME has given us levels of supervision. You've seen these before, I imagine. Direct supervision is the presence of the supervising physician. Now that could be a resident supervising an intern, or it could be a fellow supervising a resident, or it could be an attending supervising all levels of learners. Direct supervision is the physical presence there. Indirect supervision with direct supervision immediately available, and then indirect supervision with direct supervision available. So this is what typically happens when your team is making decisions about the care of a patient and you are available by phone or available by a knock on the door, but perhaps not physically in the room with them as they're putting in a new order. And then oversight would be more along the lines of a chart review process that goes along with supervision. So why is the balance of supervision and autonomy important, or why do we need to aim to supervise autonomy as opposed to letting the pendulum swing too far in the direction of one versus the other? Well, of course, for 2 reasons that I think you know of really intrinsically, inherently, more so than I have to tell you. But number one, what we'd like to see is as trainees become independent, the quality of care of patients continues to grow. So there doesn't exist some sort of disconnect between trainee independence and quality of care. So we'd like that line to continue straight up the middle like you see in the optimal line right there. We run into problems. You see these 2 problems listed out where we could have high trainee independence. So in this line right here, you have lots of independence, but you have a low quality of care. So you have a trainee functioning independently, but he or she's not providing good care. And then the other side of that would be where the trainee is not living up to an independence that they could based on their own skill set, but the quality of care is still running really high. All right. So if you're going to err on one of these, obviously for the sake of the patients, we want to err on the higher quality care. But we would like for the line to really exist more in the optimal direction. The other side of this is their supervision and progressive independence, and we'd like to see that as the level of competence of a resident increases, our own supervision intensity can go down with that. The ACGME would like to see that. They write that into their common program requirements, and yet we can find ourselves going on either end of the spectrum. We can over-supervise those that are quite competent, or we can under-supervise those who have not yet proven a level of competence. So I want to think then for the next few minutes about where the rubber meets the road on this. Let's think about some scenarios. We're not going to break into small groups, but I want you to think about just a couple of scenarios where supervision and autonomy come into play together. So let's take scenario A. Let's say you arrive for morning rounds on a weekday with a team that you've been working with for nearly 2 weeks. You've got a PGY3 resident, so a senior level resident who's been selected for a prestigious HEMONC fellowship. Your team was scheduled to receive 6 admissions yesterday and have 12 patients total based on your hospital's distribution of new admits. Well, upon beginning rounds, your resident reports that there are only 4 new patients and only 9 patients total. And when asked, the resident says that 1 new admission was transferred to the ICU for septic shock right after admission, and another new admission was sent home from the ER with appropriate outpatient follow-up for hypertensive urgency. Additionally, 1 previously admitted patient was transferred to the general surgery service after a CT scan done late in the afternoon for abrupt onset right upper quadrant pain was consistent with cholangitis. You did not know about any of these 3 things before you arrived. You have a brief discussion with the resident about each of these cases, and you actually agree fully with his management and the plan that he implemented for every one of those 3 patients. So then in regards to those 3 patients, just real briefly, do you feel the resident operated under appropriate supervision? And why or why not? Okay. So the answer there was that the attending should have at least have been notified about those things because after all, the patient is under the attending's name ultimately and not the resident's name. Anybody else have a thought on that? Good. All right, so the answer there was that perhaps because the management was appropriate and you're dealing with a senior level resident, he or she is acting up to their level of competence in making these decisions. So it's not necessarily, I don't think this is clear and cut. It's intentionally, to me, not quite as clear and cut. It actually, I think in a lot of ways, the answer to this first question depends on the very first 40 minutes that Dr. Thigpen put us through and what expectation was set for that trainee. So what would you say to the resident about after you hear these things? What would you tell him? What feedback would you provide? Right, so the answer there was that we make sure that he has a list of the things that the attending needs to be for sure contacted about, a list in very black and white so that there's no questions about it. Anybody might have said, good job, sounds like that's what I would have done. So we're going to talk about that. We're going to talk about that feedback sandwich that you mentioned. And so we deal with both parts of this. Hey, your care was good, communication maybe not so much, but at least you did the right thing with the patients. Would this be different if this was a PGY2 resident in July, especially if he or she had a subpar reputation? Would you handle that differently? And then what about this? And this to me I think is a little bit of a harder question. How would your feelings and how would your discussion with the resident change if you found out that the patient, specifically the one sent home from the ER with hypertensive urgency, returned to the ER 2 days later with an aortic dissection? How do you reapproach the resident in a scenario like that? Well, in the scenario, and the scenario is meant to be sort of vague about it, but the scenario implies that the resident had a discussion with the ED physician and felt like that with appropriate follow-up, this could be considered hypertensive urgency and sent home. There's a lot more details we would get into. I think that's really good. I think it's important to acknowledge the bad outcome. If we've done medicine long enough, we recognize that even when we do the right thing, sometimes bad outcomes happen. I think that may be something that the resident needs to hear. It may have been that the appropriate thing was done. Again, I intentionally left the scenario vague. But it may be that a poor outcome that happens 48 hours after the somewhat autonomous decision was made doesn't necessarily change where balance of supervision and autonomy can happen. All right, let's think about 2 other scenarios. We're going to move through these next 2 a little bit quicker. Scenario B is that you're in the midst of hospital rounds with 2 interns and 2 junior medical students. The senior resident has the day off. Today you find the team's presentations and thoughts to be scattered. Today, for example, the students are presenting a data fairly accurately, but when it comes time for a plan on an asymptomatic patient admitted with an elevated BUN and creatinine values, they respond, "We wanted to see what you thought we should do." Now, on other days, the students, as well as the entire team, have outlined a pretty reasonable plan well. And so you look towards the interns and ask for their thoughts. And one of them responds, "Well, this looks like renal failure. I haven't done renal yet, so I'm not really sure." The other intern says, somewhat inquisitively, "Should we give him some fluids?" I don't know if he's talking about the patient or the other intern there. But on prior days, the interns have seemed very sure of their plans. So we have a resident with a day off and interns that are struggling to formulate a plan. In regards to this team, how would you describe the supervision the interns need on the resident's day off? Higher, lower, or the same? We'll make it multiple choice. It sure sounds like it needs to be a little higher, right? Thank you. So more importantly, what could you say to the students and the interns to provide them some autonomy in caring for this particular patient? Do you have to look at them and say, okay, for this patient, we are going to order tests A, B, C, and D and begin X fluid at Y rate for Z hours? Or is there a way to still pull out some autonomy in their own decision making, even when they seem a bit clueless on what to do? Just think about that. We won't answer that one out loud. And then what advice would you provide to the senior resident when she returns from her day off? From what you know, which is not much, do you feel she is doing her job as the team leader appropriately? What do y'all think about that? Is this scenario right here, is this a senior resident problem? Excellent. So you need to dissect out what their medical knowledge, what their own medical knowledge is in the absence of the senior resident. And yet at the same time, I think what you have here is an example of a senior resident who's providing appropriate supervision to their team. And one reason the team has a pretty good idea of the plan every day is that the senior resident is supervising them. Is she over-supervising them? Well, I think that's where you have to tease it out just a little bit, as was said. You have to pull that information out of her. You may have to tell her, all right, when we start talking about plans, I want you to back off just a little bit so that I can see what these learners know as we walk our way through it. And then a third scenario, let's say it's Monday. This is an outpatient scenario. You receive a text from a PGY2 resident that you supervise in clinic, and he says that a patient you saw together 3 weeks ago and began on lisinopril 20 milligrams has called the office complaining of a cough. And he asks if you think the patient should be brought in for a visit. And then that same week, on Wednesday, the same PGY2 calls you at an appropriate time to ask if he should call in antibiotics for a clinic patient who called complaining of 2 days of congestion, rhinorrhea, and cough. And then on Friday, which is your day to work with him in clinic, the resident says to you, look, I'm really sorry to text you all the time. I'm just still not comfortable with all this clinic stuff. Thanks for not making me feel dumb. So, what's encouraging about this and what's discouraging about this? The encouraging part is what? He's at least asking for help, right? What's the discouraging part? He's asking for help on things perhaps that a PGY2 should not necessarily need specific help on. You would perhaps, probably, I would expect my PGY2 residents to understand ACE inhibitor-induced cough and understand appropriate use of antibiotics for acute sinusitis. And so I think both the asking for help is both encouraging and discouraging. So how are you going to get him to show more autonomy? I think what you can do here, and Calvin mentioned this, and it will be mentioned again, is ask for him to commit when he calls with a question. Ask for him to commit to an answer, to commit to what he wants to do before every time he calls with a question. I think that's a simple step to at least begin to flourish his autonomy. All right, just for the sake of time, we're going to keep moving. So supervision, autonomy, it's a seesaw affair. It goes back and forth. I want to spend the bulk of the rest of our time thinking about ways that you and I can still provide autonomy to our trainees, even in the setting where the supervision necessitates us to make sure we're thinking about high-value care, quality measures, length of stay, quality care, all that sort of stuff. So let's think for a second about what we can do to give autonomy to our trainees. And sometimes this just relies on how do we talk to them, how do we speak to them, how do we ask them questions. So who do your residents resemble? I'm not calling residents children here. So the residents that are in the room, not calling any of them children. But when I see and I think about the employees, and if we extrapolate that to the trainees that we're talking about, if they relish the opportunities to learn and grow, that makes me think about my own kids and what they relish the opportunity to do, to learn and grow. And so in order to think about autonomy, I'm actually going to take you back a place you never thought you would go today, and that is to the preschool education literature, right? We're going all the way back to the preschool education literature, and I'm going to give you 8 things that Dr. Grossman lists as ways we can develop autonomy in our preschool and kindergarten age children, and then I want you to think about what that looks like in your medical education, because I think it has direct consequences on what we do on the wards or in the clinic. All right, we're going to actually look at these one by one, so I'm going to go through these 2 slides fairly quick, but there's all 8 of them. The first one is that children who do not develop autonomy may feel doubtful of their abilities and be unable to take risks that lead to real learning. So how can I incorporate that in what I'm doing with my residents, my interns, my students, and maybe my fellows? Well, number 1, avoid telling your residents and interns what to do until absolutely necessary. And I would argue that unless time is really crunching you, it's rarely absolutely necessary. So we need to get away from a telling them what to do. We ought to learn to ask questions to let them get to what needs to be done, and we may have to step them all the way back through to some pathology they learned as M2s to do that. But we ought to be asking questions so that their mind makes jumps to get to the point where they know what to do in certain situations. Because then, as was mentioned earlier, you're developing a thought process. You're not creating, a well-trained animal to just follow a command of sit. You're actually creating a thought process. Why am I doing this? They're asking themselves that. So avoid telling your residents and interns what to do until absolutely necessary. That's my first rule for you as you develop autonomy in your learners. My second rule comes from the fact that for our kindergartners, self-esteem grows when we successfully do things for ourselves. So as an attending, I would encourage you to know all that you need to know about the patients you're taking care of, but avoid letting on to the trainees all that you actually know. Okay? So let me give you an example. Let's say you order a CT scan on a patient. You decide to do that on morning rounds. And the CT gets done over lunch. And the radiologist calls you, because you're the attending of record, at 1:30 to report out some finding. Unless that finding needs intervention, time-sensitive intervention, in other words, there's an impending aortic dissection and we need to get CT surgery on board right now before this patient crumps, go ahead and let your resident discover that, even if that's a 30-minute, a 1-hour lag time for when you were called with the information. Because then he's going to have to contact you, or she's going to have to contact you, not just with the information, but the plan. Because if you call them and say, hey, radiology just called me, and so has diffuse lymphadenopathy, so we need to go ahead and schedule surgery to do a biopsy. Well, not only have you told them the results, you've told them the plan before they had a chance to either discover the results or decipher the plan on their own. So sometimes as attendings, we have to hold back and avoid telling them everything that we know. Let them discover it themselves. That's a big step in autonomy. Thirdly, making choices is part of problem solving. That comes from the kindergarten literature. It's not any different for the medical education literature. Force your residents to commit to at least some part of a plan or decision. Even if they can't commit to the whole thing, try to get them to commit to at least one aspect of it. And the next day they can commit to something else. Commitment's so important. You're going to hear that time and again. And then when possible, try to incorporate what they committed to, which is sometimes hard for us. Because point number 4 from the literature says that children feel more committed to an activity they have chosen for themselves. One of the difficult tasks for us as attendings is that we figure out how to be flexible in adjusting our own style. You know, if we're going to allow our trainees to formulate a plan and then ask them to commit to a plan, and then we're going to come back and say, well, that's not the way I do it. I always do it this way. Especially if both plans kind of have equal value, then we may have just pulled the rug out from under their own commitment. Now, this is where the art of not letting them get off on an overly expensive rabbit trail or not letting them do harm to the patient is really important, right? So if your resident comes up with a plan that says we're going to consult neurosurgery for an open brain biopsy, and I've already called them and they're on the schedule tomorrow, and we think maybe an open brain biopsy is probably not the thing to do right now, might be okay to pull that back just a little bit, okay? But if we can adjust our style, if you are a Zosyn person and cefepime is sufficient antibiotic coverage, and that's what the resident chooses, you don't have to say, well, hey, I'm a Zosyn person. Can we use Zosyn instead of cefepime? If whatever infection you're presuming is going to be covered equally by both, and all other things being equal about availability in the hospital and allergies and so forth. So we don't have to necessarily, we can be flexible to adjust our own plan based on what they come up with. I think that's really important. Before they can make wise choices, children need to learn the skills of knowing the right answer. So I'm not going to spend a lot of time on this. I think it'll be covered later. But we have to make sure we're not only asking what questions, but why questions. Somebody in the audience mentioned earlier that we need to tease out what our folks know and what they don't know. And not only the what, because most residents, once they stay in a hospital for more than about 18 months, can get pretty good at knowing what because they've been in the system long enough. So if we're going to see them really grow into autonomous thinking physicians, we have to ask them the why questions. So as we talk about bedside rounding here in a second, think about ways to ask those why questions. Learning to be autonomous and self-reliant takes time and practice. And then along the same lines, this is kindergartners, but it also can apply to our own trainees. They need time, support, and practice, as well as patient teachers to help them learn this skill. I have a 12-year-old, a 10-year-old, and an 8-year-old. My wife went out of town this week, and so you would think that with me and the 3 kids, she left us with like this ultimate level of autonomy, right? Her going out of town is so much more work than her staying in town, right? All the things that she has to do to make sure that we can function autonomously when she goes out of town is astronomical. Like, I apologize for her that she was going out of town. I'm sorry that you had to cook lunches ahead of time. I'm sorry that you had to write down for me the soccer schedule and the gymnastics schedule and all that kind of stuff. And some of that may be that I need to be doing a little bit better job. But I think it's also true of us as attendings. It's actually a lot easier to over-supervise than it is to to appropriately supervise. It's much more difficult, much more time-consuming to allow our trainees to have autonomy. There's a misconception out there. I have a brother who I love who's not in medical education who kids me all the time that says all you do is just let the residents make every decision while you sit there, and I don't know what he thinks I do. And he's being funny, but the perception is wrong. It actually takes more of your own effort and your own brain power to know what's going on behind the scenes, to make sure the quality of care is still good, while also allowing your trainees to have autonomy. So be in it for the long haul. And then finally, this goes back to the second example we looked at. Younger children manage better with fewer options. So when those interns and medical students didn't know what to do with that patient with elevated BU to creatinine ratio, it may be that what we need to do to give them some autonomy is give them an A or B option. Perhaps A and B are both equally valid. That would be even better, because then they have a choice to commit to 2 equally valid ways of treating or diagnosing a patient. But sometimes we have to step that back. One of the things that was mentioned earlier about prioritizing high priority and low priority and things like that, for your interns especially, and maybe your medical students too, encourage them to make choices in the non-essentials early in their career. So I love to give interns choices on what to do for a patient for whom the nurse has called them because the patient is constipated. Because there's like 50 ways to treat constipation. And there are some instances where you have to choose one, but in many instances you have multiple right answers. So I tell them, read about constipation and make a choice on what to do. It's a non-essential in most cases. And when you force them to make decisions in non-essentials, they become better in making decisions in the essentials. My son is a big Star Wars fan. Part of the reason he's a big Star Wars fan is because I haven't let him watch episode 1, 2, and 3 yet. But in episode 1 of Star Wars, and if you are waiting to watch Star Wars, I'm sorry that I'm going to ruin the ending, Anakin Skywalker becomes Darth Vader. And in the very first episode of Star Wars, there's this scene where his shadow reflects that of Darth Vader. The reason that he was not allowed to be trained to be a Jedi was because he was too old, because they started too late. If we allow autonomy to start too late, we end up with people going way out of control. So we provide graded autonomy early on in their training. Real briefly, supervision. Again, I think you hear a lot about supervision. If you are here, you have passed tests all along the way, like step exams and board exams and all this kind of stuff. And if you passed a test, you almost certainly memorized a mnemonic or two. So there's a great mnemonic for if you have a resident, if you have a resident or an intern or a fellow that you need to give some guidance to in supervision, someone who is not perhaps notifying you when they should, there's a great mnemonic that came out in 2010 in the Journal of Graduate Medical Education from these authors. You may have seen it. It's made its rounds before in these types of conferences. It's called Superb Safety. So what are the things that the attending needs to do to provide right supervision, and what are the things the resident needs to do to ask for correct supervision? So the attending needs to set expectations for notification. This came back to the very first question in the very first scenario we dealt with. Our hospital has an attending must-call list. There are 10 things on that list for which the resident is not expected to act without touching base with his or her attending. If there is uncertainty, so in your expectations, as you tell the team, I'm the coach and you're the quarterback, look at your quarterback and say, sometimes the quarterback doesn't know what to do, and he looks over to the sidelines, and that's okay. If you don't know what to do, you look over to the sidelines. I may not be around all the time, but I'm always a phone call away. And that's the personal communication part. Make yourself easily available. Make sure they have your contact, your access, know where your office is. Come back by, check in on them in the afternoon if you have freedom in your schedule to do that. Reassure their fears, and then balance the supervision and autonomy is kind of what we've been talking about. Tell them, don't worry about waking me up. Don't everything you say about calling your attending as a sign of weakness is not true. All right, we need to remind them of that. And then the resident guide for attending input. I'm moving fast here because I've gone over time. But for residents, we want them to seek the attending input early, especially in scenarios where the direction a patient goes is contingent upon a decision. You want to be part of active clinical decisions. So if you've gotten that CT scan back and it has led to choice A or choice B, it's nice when the resident chooses A or B and has a plan, but they contact you to let you know of that plan because it's an active decision making. They always want to contact you if they feel uncertain. Definitely want to contact you for end-of-life discussions, for transitions of care, which should be on the must-call list. And then if there's systems issues, this is a big point of emphasis for our own residents at our institution is don't let the system be a hindrance without letting your attending know. So if I need to call the attending on a consult service, you let me know, and you let me know early. So those are the things that we can give them that provides them supervision, and it's supervision that's put in the context of them still developing their own autonomy. We're offering them choices. This is their concluding sentence from this particular article. We're offering them choices, but we're not giving them complete control of the classroom. Since the children may choose only from one of the alternatives offered, the teacher maintains control of what the options are. And that's really what supervising autonomy looks like. We want our trainees making choices, but we want them making choices within the context of our umbrella, of our sphere of safety, of all of those other sorts of things. I think this is the most fun and the most challenging part of our job if you're an attending physician. Most of us could much easier simply do the patient care, do the supervision, and kind of move on. But learning how to give others just enough rope so that they walk away just a little bit, but you pull them back before they get to the cliff, I actually think that's the most fun part of what we get to do.